Dr. Satyajeet Mishra, who is an assistant professor at Sri Chitra Tirunal Institute of Medical Sciences. Of course, everybody knows that this is a specialized and highly specialized center. He has got a number of publications in both Indian as well as international journals, and his areas of interest are transesophageal echo, assessing the depth of anesthesia, sedation in the intensive care unit, and neuroprotection. Dr. Mishra is going to discuss which patients should have preoperative cardiac evaluation. I presume he means the patients coming for non-cardiac surgery. Correct me if I'm wrong. Dr. Mishra, please.
Thank you, sir, for the generous introduction. Yeah, I guess that's an oversight that I didn't mention the surgery, but it's obviously patients coming for non-cardiac surgery, because patients coming for cardiac surgery are well worked up for the cardiac evaluation. Now, I'll try and finish within the allotted time. So we'll start straight away with the presentation. So patients coming for non-cardiac surgery, who actually needs a preoperative cardiac evaluation? I'm sure most of you sitting here must have faced this dilemma at some point of time as to whether to refer a patient for a further cardiac evaluation or whether to take the patient straight to the operating table. So in the next few slides, I'll try and clear up a few of the controversies. And we'll start by delineating two case scenarios. The first is a 70-year-old man who suffers from a lifestyle-limiting claudication of the legs, and he's posted for an aortobifemoral vascular repair surgery. His functional class is pretty much unknown because of the claudication, but he gives no history of comorbidities or any clinical risk factors. Would you like to order any preoperative cardiac tests in this patient? If so, what? The second case scenario is a 55-year-old man who's posted for a prostate surgery. He gives a history of acute coronary syndrome some 6 years back, and he's a diabetic on oral hypoglycemic. He leads a sedentary lifestyle, and despite that he complains of occasional anginal pain, and he takes nitrates, aspirin, and beta blockers. What are the preoperative cardiac tests you'd like to order in this patient? With that, we move on to the topic per se. What exactly is the scope of the problem? I mean, why are we even discussing this issue? If you look at the incidence of major cardiac outcome, that means both non-fatal myocardial infarction as well as cardiovascular death. In patients who are undergoing non-cardiac surgery, it's to the tune of 1.5% in unselected patients to as high as 4% in patients at risk. Now, although older age is per se not associated with an independent risk factor, what it does is it adds to a number of risk factors which may ultimately influence the cardiovascular outcome. And incidentally, the maximum surgical procedures are actually performed in this age group, which make it a very dicey proposition. There is also a lack of consensus on how best to stratify the preoperative cardiac risk, in part because of a number of risk scoring systems. And therefore, the practice patterns has differed very widely amongst clinicians, which often leads to an overuse of testing, which may not only increase costs, but it can also cause direct as well as indirect patient harm. Now, in 2007, the American College of Cardiology and the American Heart Association came up with the guidelines as to which patients should undergo further preoperative cardiac risk stratification before non-cardiac surgery, as well as the care of such patients who undergo non-cardiac surgery. Now, the aim of the guideline has been principally to bring about a decrease in the overuse of preoperative cardiac tests in order to not only improve not only decrease the costs, but also to improve the overall patient outcome. The first of the guidelines actually came in 1996. It was subsequently revised in 2002, and the latest revision was in 2007. There's been a focused update in 2009 after that, but there's been no change in the guidelines as such. Now, the overriding theme of the guideline is if the patient is a patient of coronary artery disease but is having a stable coronary artery disease, medical optimization and management of the patient is much better than subjecting him to coronary revascularization. So how do we actually use the guideline in deciding which patients should be actually referred for further cardiac testing? What it does, it integrates 4 important factors, 3 of which are patient related and 1 is a surgical factor. The patient related factors are whether the patient has any active cardiac condition. I'll come on to what exactly constitutes an active cardiac condition. Whether the patient has any clinical risk factor or suffers from any comorbidities, and what exactly is the functional class of the patient, which is a very important measure of whether the patient will be able to withstand the stress of the surgery. The 4th factor is the inherent risk of the surgery itself, how the risk of the surgery adds to the overall cardiovascular risk. And so that also is an important consideration in deciding whether these patients need to be stratified further with respect to preoperative cardiac risk. So coming on to the first factor, that's active cardiac condition. In previous guidelines, they have been called as major risk predictors. And there are 4 active cardiac conditions. The first is unstable coronary syndrome. That means any recent myocardial infarction or unstable angina, which happens within 7 to 30 days of the proposed surgery. If the patient is decompensated congestive heart failure patient, like for example, the patient is in NYHA class 3 or 4, he complains of dyspnea, orthopnea, there are rails on examination, there's a raised JVP, there's a third heart sound, etc. The patient suffers from significant arrhythmia, both symptomatic bradycardia as high-grade AV blocks, or significant tachyarrhythmias like supraventricular tachyarrhythmias or ventricular arrhythmias with an uncontrolled rate. Or if the patient is has a severe valvular disease, either he has severe aortic or mitral stenosis or is symptomatic for the valvular disease. The second important consideration that we need to evaluate is whether the patient has any clinical risk factors. Again, in previous guidelines, these were termed as intermediate risk factors. That is, you have to elicit whether the patient had a history of past ischemic heart disease, as evidenced by Q waves on the ECG, etc. Whether the patient had any history of previous congestive cardiac failure, whether the patient gives a history of stroke or transient ischemic attack, whether the patient is diabetic, and whether the patient has renal insufficiency. That means a serum creatinine of more than 2 grams per dl. Now, comorbidities are by themselves not independent risk factors, but what they do is they add to the overall cardiovascular risk in the sense that they modify the overall outcomes. For example, age, like I mentioned, it rarely comes alone. It comes with a host of other disease, other problems like diabetes or hypertension or renal insufficiency, all of which can compound the cardiovascular problem. If the patient has a history of pulmonary disease like both restrictive as well as obstructive lung disease, again this can add to the cardiovascular burden. Anemia is bad in the patient who is undergoing a surgery, but if the patient also has ischemic heart disease, it's even worse. And uncontrolled systemic hypertension, again not an independent marker, but what it does is it increases the risk for coronary artery disease as well as stroke. Functional class is a very good ability, or the patient's very good ability, whether the patient, very good method by which you can judge whether the patient will be able to withstand the stress of the surgery. And it's actually what it does is it aims to measure the oxygen uptake of the patient in day-to-day activities. It's expressed as metabolic equivalence, and 1 meds is roughly around 3.5 ml of oxygen per kg per minute. Therefore, if your patient gives a good functional class history, like say the patient is able to do most of his work, he's able to walk on level ground at more than 6 to 7 kilometers per hour, he's able to climb a flight or 2 of stairs without any significant problems or symptoms, that means the patient has a good chance to withstand the non-cardiac surgery. The fourth factor that's embedded in the risk scoring system is the inherent risk of the surgery itself. Now, some of the surgeries are considered to be high-risk surgeries. For example, the combined incidence of non-fatal myocardial infarction as well as cardiovascular death is more than 5% in patients who undergo major surgeries or emergent surgeries or major surgeries like a AAA repair, peripheral vascular surgery, or any surgery which is prolonged in nature and associated with much fluid shifts as well as blood loss. Some of the surgeries have a risk more than 1%, but the overall risk is less than 5%. For example, most of the intraperitoneal or intrathoracic procedures that are undertaken on a daily basis, carotid endarterectomies, your orthopedic and prosthetic surgeries, and endoscopic aneurysm repairs. And in some surgery, you can pretty much take the patient straight away to the operating table without any further risk stratification, where the total incidence of cardiovascular death as well as non-fatal myocardial infarction is less than 1%. So your superficial procedures like breast and cataract surgeries or dental or dermatological procedures, daycare surgeries, all fall in this group. So how exactly do we use the algorithm? The first is if you need to determine whether the patient needs an emergency or an elective surgery. If the patient needs an emergency non-cardiac surgery, you can pretty much take the patient to the operating table without any preoperative cardiac risk stratification, and you keep a high index of suspicion for CAD. You do an intraoperative surveillance as well as post-operative surveillance for myocardial infarction. If on the other hand, the patient needs an elective major non-cardiac surgery, you determine whether the patient has any active cardiac conditions, as I previously mentioned, that is whether the patient is having an acute coronary syndrome, whether the patient is in decompensated congestive heart failure, whether the patient has high-grade arrhythmias and is symptomatic because of it, or whether the patient has any significant valvular heart disease. If the patient has any of these conditions, you postpone the elective surgery and you evaluate and treat the condition, and then later on take the patient for the non-cardiac surgery. If the patient is undergoing an elective surgery without any active cardiac conditions and is undergoing a low-risk surgery, you can straight away take the patient to the operating table without the need of determination of any further cardiac risk scoring systems. If, on the other hand, the patient undergoes an intermediate to high-risk elective surgery, but he gives a very good functional class history. He says that I'm able to jog, I'm able to do most of my work, I can climb flights of stairs without any problem. You can again go with the planned surgery without the need to delay for any non-invasive cardiac testing. Now the algorithm gets a little more complicated. If the patient is undergoing an intermediate to high risk elective surgery, but his functional class is unknown by virtue of either the disease modifying the lifestyle or whether because of deconditioning, etc., you need to elicit whether the patient has any history of clinical risk factors. You need to find out whether the patient had any prior MI, whether the patient ever was hospitalized for previous congestive cardiac failure, whether the patient has diabetes, or whether the patient has renal insufficiency. If the answer to all these questions is no, then you can again take the patient for the non-cardiac surgery without actually putting him to further battery of preoperative cardiac tests. Now here is where the algorithm is quite complicated, and the AHA actually leaves the decision to the individual clinician who is caring for such patient. Say, for example, you don't know the functional class of the patient who is coming for an intermediate to high risk elective surgery. The patient gives a history of 1 to 2 clinical risk factors. Say the patient says that he's diabetic, and the patient says that he had some history of myocardial infarction, and he's undergoing either an intermediate or a high-risk surgery. If the patient is well optimized with respect to his heart rate by virtue of treatment with beta blockers, probably you can still consider taking this patient straight away to surgery without the need to delay for any non-invasive cardiac testing. If the patient is not well optimized, if he has tachycardia and he gives some history of dyspnea or angina, probably you can consider non-invasive testing if you feel that it will change the management. If the patient has 3 clinical risk factors, his functional class is not known, and he comes in for an intermediate to high risk elective non-cardiac surgery, you can go in for a testing non-invasive. Further, you can stratify with respect to cardiac risk with other non-invasive tests if you feel that it will affect the outcome. Now, amongst the various tests that we have, we'll just see what are the recommendations for some of the tests. Now, if you take a baseline ECG, I can tell you that it's not recommended in the asymptomatic patients who are undergoing low-risk surgery without any clinical risk factors. However, you can consider doing it in patients who are undergoing high-risk surgery or patients undergoing intermediate risk surgery with at least 1 clinical factor. Say the patient is undergoing an intraperitoneal or intrathoracic procedure and he is diabetic, so probably you can go in for a baseline ECG. If the patient is undergoing a low-risk surgery and has a clinical risk factor, you can probably consider going in for a baseline ECG. Having said that, if the patient has a documented ECG, anytime within 30 days of the planned surgery, you probably don't need to repeat another ECG. Now, echocardiography is one of the most commonly performed non-invasive cardiac examinations in patients who are undergoing non-cardiac surgery. But then again, there's a clear-cut recommendation that it's not useful in the asymptomatic patient who is undergoing an intermediate to low-risk surgery and without the presence of any clinical risk factors. There has been a lot of debate, but generally the consensus is probably it's useful in patients who are undergoing the highest kind of highest risk surgery, like a AAA repair. Or if the patient is symptomatic and doesn't have a previous diagnosis, probably in those patients you can consider doing a rest echocardiography. If the patient is a known heart failure patient and has had no evaluation in the last 2 years, or if the patient is a known heart failure patient with worsening of symptoms, probably you can still go in for a rest echocardiography. If your patient has a diastolic murmur or is symptomatic with systolic murmurs, again you can consider a rest echocardiography. And patients with prosthetic heart valves, probably you need to go in for a rest echocardiography to determine the status of the valves. Now, I'd like to draw your attention to an important paper that was published in the BMJ by the Toronto group, where they tried to see if the resting echocardiography performed before major elective non-cardiac surgery actually results in improved patient outcome in terms of improved post-operative survival or a decreased length of hospital stay. Now, what they found was that the preoperative echocardiography is actually not associated with either improved survivals or shorter hospital stay in patients who are undergoing major elective non-cardiac surgery. But more importantly, if you perform echocardiography in patients who are undergoing intermediate to low risk surgery, routine use is associated with more harm and worse outcomes than good. Now, indications for non-invasive stress test, I'll just brush through this again. If your patient has any active cardiac condition, obviously you need to stratify the cardiac risk, and probably you need to delay the non-cardiac surgery. If your patient has poor or unknown function class, undergoes a high-risk surgery with at least 3 clinical risk factors, you may consider going in for a non-invasive stress test. Again, if you feel if it changes the management, and you may consider it patients with 1 to 2 clinical risk factors who are undergoing intermediate to high-risk surgery. It's definitely not recommended in patients who are undergoing surgery without any clinical risk factors, or in patients who are undergoing low-risk surgery. Now, there are various types of tests. In most of the patients who are ambulatory with a normal resting ECG, you can actually go in for an exercise ECG testing. Now, 20 to 50% of patients with a normal resting ECG will have abnormalities on the exercise ECG, and this incidence actually increases if your patient has ischemic heart disease. If your patient is ambulatory but has significant abnormalities on the resting ECG which precludes interpretation with an exercise ECG testing, you can contemplate taking these patients for a pharmacological stress testing in the form of either a dobutamine stress echocardiography or a dipyridamole thallium scan. This is also recommended for patients who are non-ambulatory or those who cannot generate an adequate response on the treadmill. So we'll take on to the 2 case scenarios. The first was the 70-year-old man with the claudication of legs and posted for the peripheral vascular surgery. So we'll go for the step 5 of the algorithm. This is an elective non-cardiac surgery. There are no active cardiac condition, and it's a high-risk surgery. Now, the functional class is unknown because of the claudication. There are no clinical risk factors. The patient doesn't give any history of any clinical risk factors. You can actually, according to the guidelines, you can actually proceed to the planned surgery without the need for any echo, without the need for any exercise, without the need for any pharmacological stress testing, etc. If at all you need to do something as a baseline measure, you can consider doing a baseline ECG. If you look at the second case scenario, a 55-year-old man posted for a prostate surgery. So again, we use the step 5 algorithm, and this patient has an intermediate risk surgery. Prostate surgery is an intermediate risk surgery. He gives 2 clinical risk factors. He gives a history of acute coronary syndrome some 6 years back, and he's a diabetic on oral hypoglycemic. His functional class is unknown because of his sedentary lifestyle. He complains of occasional anginal pain, but he's on beta blockers. So if the patient is well optimized with the heart rate, say the heart rate is between 60 to 70, there's a tight heart rate control, you can take the patient straight away to the operating table without the need for any further non-invasive testing. If on the other hand, the patient gives a history of more severe angina or a history of more severe dyspnea, probably you can consider doing a stress test. Thank you, and I believe I've done justice to the time.
Thank you very much, Dr. Satyajeet. May I have any comments or questions from the floor, please? Please. Please, would you mind mentioning your name, please?
Yeah, Dr. Abhay Patwari from Kuwait. You mentioned that echocardiography done preoperatively worsens outcome. Echocardiography is a non-invasive investigation. If it might help, it might not help. But how does it worsen the outcome of surgery? I don't understand.
Yeah. So many of the things that we find on echocardiography, like say for example, a regional wall motion abnormality, which may be indicative of a coronary artery disease. What these authors actually found was that they commented on 2 things. One is the subjective nature of the examination itself. For example, I may find a systolic dysfunction and you may not find a systolic dysfunction. Again, I may find that there is a regional wall motion abnormality in this area and you may not find that. So it's a very subjective examination. The second thing is that The second thing is that if an abnormality was detected in a patient who was undergoing either an intermediate or a low risk surgery, it led to actually use of medications like beta blockers or angiotensin converting enzyme inhibitors, etc., to try and mitigate these risk factors, which actually led to more chances of hypotension, more chances of hypoperfusion, and worsened outcomes. So they found that testing actually led to an overuse of drug prescription in these patients, which was associated with a more torrid intraoperative and postoperative period, leading to worse outcomes. Therefore, the recommendation is, if your patient is asymptomatic, if your patient is leading a comfortable life, if your patient is undergoing an intermediate to low risk surgery, probably there's no need to actually do a resting echocardiography.
When we refer a patient to the cardiologist for evaluation, he examines and then he decides this patient does not need echocardiography. I don't tell him to do an echocardiography.
Yeah, so that is where you should make the change now. The guidelines are there for all to follow, and you are the perioperative physician. It's your responsibility, and not the cardiologist. When the patient is taken to the operating theater, it's you who's the primary physician who's responsible. So you need to decide what are the tests that you need to order in this patient, and if you follow the guidelines, you'll actually see that it streamlines your approach to the management.
May I interrupt here, please? Dr. Patwari, thank you very much. The question was regarding the outcome, not only as Satyajeet has mentioned about the additional medications and increased comorbidity, there is also increased length of the stay because of additional investigations and possibly invasive monitoring which might be employed during the anesthetic. So when the authors mentioned worst outcome, it was involving not only the patient outcome of survival, but also involving the other parameters of the patient's lifestyle, the additional medication, length of stay, and the cost to the economy.
Correct.
Dr. Satyajeet, thank you very much for very elaborate presentation, and it was very informative, particularly for those of us who do not practice